Welcome back to the channel. Today we are reviewing the open reduction and internal fixation of proximal ulnar shaft fracture. Though the preoperative X-ray looks undisplaced ulnar fracture, it was associated with radial head dislocation. So it's a Monteggia Fracture-Dislocation, and restoring anatomical length and alignment of ulna is absolute requirement to achieve stable indirect reduction of the radial head. The patient is placed in the left lateral decubitus position with affected arm draped over a padded post, allowing the forearm to hang freely. This position utilizes gravity to flex the elbow, providing excellent stable access to posterior aspect of the ulna. Next, we identify our landmarks. The subcutaneous border of ulna is easily palpable along its entire length. We mark our planned longitudinal incision directly over the border, centering it over the fracture site. Incision is made through the skin, and we use electrocautery to achieve meticulous hemostasis of the superficial breathing vessels. We then incise the subcutaneous tissue and the deep fascia in the line of skin incision. Now we exploit the classic internervous plane between extensor carpi ulnaris provided by PIN and flexor carpi ulnaris innervated by ulnar nerve. Because the ulnar shaft is subcutaneous, we can safely perform direct sharp incision to the bone. Using a periosteal elevator, the muscle attachments are subperiosteally elevated just enough to expose the fracture end and accommodate our plate. We want to minimize soft tissue stripping to preserve the local blood supply, which is critical for bone healing. Once the site is adequately exposed, a thorough wound wash is performed. In this case, the fracture was not significantly displaced, so achieving anatomical reduction was straightforward. However, look what happens when we try to template a perfectly straight plate. There was exaggerated ulnar curvature. Preventing the plate helped to maintain the reduction. Preventing the plate to maintain proximal ulnar curvature is the most important part for radial head reduction as well as for successful surgery. Once contoured, we check every plate hole is in flush contact with the bone and that our planned screw trajectories are clear. Satisfied with the fit, we secure the plate temporarily using Alice forceps to maintain our reduction. Now, for the fixation sequence, we begin proximally using 2.5 mm drill bit. We drill our first hole through the second proximal plate hole. We measure the length using depth gauge and insert an appropriate length cortical screw, leaving it snug but not fully tightened. Next, we move distal to fracture line to achieve the compression. We place our drill bit in the eccentric fashion in the second distal hole, drilling away from the fracture line. We gauge the depth and insert the screw. With absolute stability achieved, the remaining screw holes are drilled, measured, and filled in the standard bicortical fashion. Following definitive fixation, the wound is aggressively irrigated to clear any bony debris and other clots. To decrease the risk of surgical site infections, especially with the subcutaneous nature of ulna, we routinely apply intra-wound vancomycin powder directly over the implant. Closure is performed carefully in layers to prevent dead space. The deep fascial layer is closed using 2-0 vicryl in interrupted fashion. This is followed by interrupted closure of subcutaneous layer to approximate the wound edge without tension. Finally, the skin is closed using vertical mattress suture technique. This maximizes wound edge eversion and ensures a clean cosmetic scar along a highly mobile joint area. The radial head stability was checked intraoperatively and found to be perfectly stable. And here is our final postoperative result: anatomic reduction of ulna and perfectly reduced radial head. If you found this step-by-step breakdown helpful to your orthopedic practice, please hit the like button, leave your questions in the comment box, and subscribe for more surgical videos. See you in the next one.